Hello, I am Mr. Ronga, consultant gynecologist, specializing in endometriosis, lead for the Midland Metropolitan Endometriosis Center. I'd like to thank the British Society of Gynaecology for the opportunity of presenting this poster. I entitled it, I Respectfully Disagree, and it's a patient-centered analysis of the 2026 BSGE new accreditation criteria. The objective is to critically appraise the new accreditation standards and propose further improvement. This does not intend to be really a criticism, but a plea for further improvement, for further advancing the goal of improving patient care. So I conducted a gap analysis of the new accreditation criteria based on GIRFT, NICE and RCOG recommendation, and I selected the most relevant missing or partially overlooked benchmarks. There is a lot to praise about the good work that's been undertaken with the new criteria. A lot of hard work behind and a much clearer and standardized criteria than previously. For example, having CNS protected hours, having the #NCIAN index cases for inclusion, the creation of the ultrasound scan lead, the planning of collecting Clavien-Dindo post-operative complications. A lot of good things are happening with these new criteria. I think there is still opportunity to improve and to move even further. Unlike the BSGE accreditation to be even more patient-centered, to take a greater consideration for well-being and mental health, an inclusion of shared decision-making as standard. Perhaps the index criteria and the relationship with the MDT could be better. The complications collection analysis could be better, and the outcomes perhaps too. Trying to be concrete, I think we should have anxiety and depression with unstandardized action pathway. So it's not enough asking the patient if they've been anxious or stressed or having troubling or having difficulties with cope with normal life. The answers should have a clear action pathway that has to be applied for all centers. GAT7, PHQ9, they have thresholds on what we recommend, or it is recommended the initiation of treatment. Whatever metric we use, we should have included an action pathway. I think we should be routinely screening for central sensitization syndrome. Again, should have a standardized pathway, so there is a clear action after the diagnosis. We should have validated shared decision making for all our index cases. Now, as with regards index cases and MDT, we have cases where the torus is affected, there is no bowel or ureteric affection. Why we need to involve colorectal and urologists? Radiologists, yes, maybe sometimes, but as people, as gynecologists, skills with scanning progresses, we may not need to, providing we are following the right patient-centered care, providing that the patient has been offered all the options. There is no need to create a white elephant where we involve professionals, specialists, that they're not going to be, the colorectal surgeon will not be, most of the times, will not be detaching the bowel so we can shave the torus. Most commonly that's done by the gynecologist. Similarly, with a large nodule on the compartment B, providing there is no ureteric involvement, there is no need to involve other specialists in the MDT. As for complications, perhaps we should make use of class intra for intraoperative complications. And as for outcomes, perhaps we should establish and utilize patient-reported outcomes. Thank you very much for listening.